3 of what the nurse needs to know about Ehlers-Danlos syndrome will give an overview of the nursing care for the patient with EDS. By the completion of this section, you will be able to recognize 2 patient care priorities in an EDS clinical patient scenario. This is an overview of the nursing care for the patient with EDS. This is a general overview, not specific to type, but does cover the most common problems encountered by most types of EDS. In this educational series, we at EDS Awareness did a survey asking sufferers of diagnosed and probable EDS what they would like nurses to know when caring for them. We wanted to educate you not only on the disease, but on what the patients really need you to know. By far, the prevalent theme throughout the survey was that they wanted healthcare workers in general to listen to their patients. Not only was this a specific answer to an open-ended question, it continued to appear as an underlying theme in most of the answers in the subtopics like pain, GI problems, and mobility issues. Nurses, we are trained to get both subjective and objective information when caring for patients. With experience, this information gathering becomes quite automatic and occurs while you're performing tasks like bringing the medication or taking a food tray away or walking them to the bathroom. As you multitask, you are not only absorbing information, but you're carrying on conversations, you're performing tasks, and you're planning future tasks. Even the best multitasker can only keep this going for a period of time before your alertness starts to decrease. Because of the pace that most nurses work at, we can sometimes witness information but not actually process it. Or you can process it for the present moment, but perhaps forget to pass it on. And it may be a simple part of someone's care to you, but it may be enormously important to the patient. First and foremost, the basis of all care is to provide safety and dignity. Never, ever underestimate the latter. Every nurse knows that patient when during handover that doesn't have just one. Every nurse knows that patient when during handover that doesn't have just one diagnosis, but 4 or 5. So you will juggle these in your assessment so that all of them are considered. With EDS as the primary diagnosis, the patient may have several secondary diagnoses and subcategories of symptoms that all are directly related to the EDS. So they must be treated in the same way. For example, they may have a severely damaged shoulder with a diagnosed problem in that shoulder, but it will be secondary to dislocations, which are secondary to EDS. EDS can affect multiple parts of the body in different ways and at different levels. So for each EDS patient, you will need to pull from that underlying knowledge you have about connective tissue and be aware of the symptoms, the limitations, and the complications that are occurring with your patient, and then adjust your care accordingly. Symptom that is experienced by over 90% of EDS patients is pain. Pain is difficult to describe and at times may be described to you in a way that's unfamiliar to you. What you need to know is that dislocations and muscle spasms, especially when they're near unstable joints, on a whole are unpleasant. Listen to your patients. Learn their pain scales. They may likely have a high pain threshold, so if they say it hurts, I assure you it does. With severe cases of hypermobility, people can dislocate fingers by simply pulling up a blanket at night. Us older EDS patients have weird painful joints that are now limited by damage and arthritis. Any pain or the fear of injury affects mood, sleep, appetite, and the general psychological well-being because it simply wears people down. Need to be able to say when they're in pain, know that you've heard them, and that you'll try to help them get some relief. This may be via medicine, it may be from assistance with mobility or positioning, or perhaps advocating with the doctor to order some physio or PT, as you call it. Most patients do benefit from some regular gentle exercise, but this may only mean a slow walk or some isometric exercises. If you've heard about a patient's pain for several days, please don't become immune to it. I can say from experience that prolonged pain is physically exhausting. If you've heard about their complaints for several days, imagine how sick of the pain the patient is. They may be irritable or fatigued or forgetful from broken sleep. There's a Facebook post showing an ultrasound photo of a fetus, and it says, "This is the last time I got a good night's sleep." It's a great representation of how you feel sometimes after prolonged pain. Pain levels vary just sometimes after prolonged pain. Pain levels vary. Just because someone can appear okay for a couple of hours, perhaps during the day, it does not mean that their pain isn't real. Acknowledge pain. Ask the patient what makes it better, what makes it worse. If a person relates any procedure or hospitalization with severe pain, their anxiety level has been up since the moment they've walked through the door. Primary needs for EDS patients is to keep moving. Movement heals. Physical therapy will always be a good option because they have not just pain but unstable joints. Mobility can sometimes lead to a safety issue. You must think, do they need a device? How to best assist them? When in doubt, speak to the physical therapist. With patients with dysautonomia or POTS, your priorities are safety, comfort, and dignity. Always use slow movements and continuously evaluate any mobility. Anyone who falls or faints is at serious risk of injury, as are you potentially. Remember that this is very embarrassing to most people. Patients who are dealing with this on a regular basis know what works for them. Listen to them. You may gently instill some nursing measures for easier transferring or teach them any safety precautions, but please listen to how your patients transfer and what works for them. They need to keep hydrated. You may hear them say that salty foods or electrolyte drinks make them feel better. You may see fluctuations in pulse, BP, temp, that may not seem normal. So with these patients, please be extra cautious not to dismiss symptoms of complications as part of their EDS. They may have fluctuations in BP temp, etc. These may be part of their POTS and dysautonomia. It may not be. Problems are extremely common with EDS and sometimes mistakenly not attributed to EDS. These problems can go either way, from a hyperactive irritable bowel to gastroparesis. Nursing measures are symptom control, nutritional status, and hemodynamics. One type of EDS causes severe periodontal issues, which makes this section even more important. Be aware of blood results. Are they anemic? Are they dehydrated? If the GI problem is prolonged, you may want to look at ferritin levels. That's reflects the amount of stored iron in the body. Are they on antibiotics? Do they have diarrhea with the antibiotics? Of course, then there's the psychological aspect of GI problems. When combined with mobility issues and pain, there is always room for embarrassment. This is where basic nursing comes in. Tissue, sick bowl, water, keep a cowbell in reach, close the curtains or pull the curtains if the patient's feeling unwell. One very basic example of this, and it's not at all memorable to the nurse or to my roommates, but I once woke up on a first day of being post-op after extensive surgery, too nauseated to eat, feeling very sick, taking morphine for the pain, which makes you more sick, and obviously at some point needed to be sick. No sick bowl. So thankfully there was a plastic bag on my table, and I proceeded to be sick while my poor roommates were eating their lunch. And my very stoic British roommates never blinked an eye. Called the call, pressed the call bell for the nurse and asked me if I was okay. Now, again, to everyone else, I'm sure they don't remember it. The nurse didn't remember it, but I was terribly embarrassed at the time, thinking, my gosh, they're finally feeling a bit better and having a nice meal, and I'm vomiting while they're having their meal. So be aware if your patient has GI problems and prepare accordingly. Most GI problems are fairly embarrassing. Urinary problems, like GI problems, require preparation. Be aware that mobility issues are going to compound any symptoms of retention, frequency, or urgency, which increases the risk of incontinence and embarrassment. Patients with EDS have skin issues, especially the classical types. These patients may experience excess bruising, bleeding, delayed healing. Sutures may not hold as well. All EDS patients may have allergic reactions or odd adverse effects to medicine, tape, staples, latex. Be very observant. Be on the lookout for anaphylaxis or any extreme allergic reactions and mast cell disorders. Involve other body systems. People may have issues with endocrine problems, GYN problems, and hemodynamics. If the patient has vascular EDS, this is highly specific to complications such as bleeding and organ rupture. Remember that this is a person trying to live their lives. These symptoms, all symptoms of EDS, can cause a great deal of disruption and anxiety to patients and families. I have heard many sufferers say that they have started and had to stop jobs, schools, courses, projects, holidays. This can have a great impact on relationships and intimacy. That your patient may have an overreactive or a suppressed immune system and a hypersensitive allergic system. They're always at risk for infection because of poor healing. Psychologically, this is a very frustrating syndrome. It's full of anxiety and frustration with chronic symptoms. When you are newly diagnosed, there is a small period of relief where you're happy that all your symptoms are attributed to something. However, then the harsh reality that this is going to go on for the rest of your life hits, and that is a daunting prospect. People who have severe symptoms with multiple traumatic experiences can often experience a PTSD-like reaction and are at high risk for depression. Graham, an EDS expert, said that no other condition in the history of modern medicine has been neglected in such a way as Ehlers-Danlos syndrome. Need reassurance that effective management of EDS is entirely possible, enabling people to lead happy, productive lives. Effective EDS management is through awareness and education. As nurses, we need to promote evidence-based care that's individualized to the patient, promotes continuity and advocacy so that the patient has confidence to navigate the healthcare systems. I'm Rebecca Holmes, the Edinburgh Area Coordinator of Ehlers-Danlos Support UK. One of the hardest parts of my work, supporting those with EDS, is having to explain over and over that services are very limited, help is difficult to find, and more often than not, patients will have to manage on their own. This is absolutely true, and even more important that you advocate for your patients, hear their complaints, and try to help them navigate the healthcare system. The overview of nursing care for the patient with EDS. First and foremost, always listen to the patient, hear what they have to say. Prioritize their pain management, validate the pain, don't underestimate it, realize they have high pain thresholds. Realize that when you are going to care for this patient, you need to go in with a multi-system symptom assessment and management plan. You will need to be aware of the impact that this disorder is having on the patient's life and on the family, and please support the patient, advocate for the patient, ask the doctor to make referrals, help the patient navigate the healthcare system. Thank you.